Tokyolive,
Live.
Endoscopy 1.
Endoscopy 1.
So hello everyone. Next session will be our Tsenka poem procedure. So one of the offshoot of the poem procedure. And this session is the moderator is Dr. Grace Santi from University Hospital of De La Salle in the Philippines. So she is the assistant professor and the training officer of gastroenterology in the Department of Gastroenterology. So Grace, please open this session.
Thank you very much, Professor Inoue, and welcome and thank you everyone for joining us in this session on Z poem. I am honored and privileged to moderate this session together with you, Prof. We are also joined by Dr. Yuto Shimomura in this discussion. He is an assistant professor of Showa at the Showa University Koto Toyosu Hospital, and his work is mainly in the field of third space endoscopy, endocytoscopy, early cancer detection, to name a few. Now to introduce our exceptional speaker. She is a good friend of mine and admirable colleague. She's Dr. Maselli, and currently she is a professor at the Humanitas Research and University Hospital in Milan, and is known for her works on GI endoscopy, particularly early cancer detection and third space endoscopy. We are very privileged to have you, Roberta. So please start your talk.
Good morning from my side, and thank you really for having me. It's a real honor. It's not just words, but a real honor to be here with you. Let me share my screen because I want to start with a special picture that Professor Inoue shared with us a few days ago, because you know that my talk and my lecture will be about Zenker poem, but everything in my journey starts from this point. It was 10 years ago, and Grace and me, we were fellow of Professor Inoue. This is where we were 10 years ago, and nothing would happen just if we were not that at that moment. So thank you for that time, and thank you for today and for tomorrow, let's say. But let's come back on the Zenker. Just have a small background. We know that the Zenker is a diverticulum in the posterior hypopharynx in this weakness area that is called the Killian triangle. And mainly and basically, we have a pouch that is herniating outside. So what we have is this esophageal diverticulum that can cause different symptoms. It's a rare disease, relatively rare. They say that the prevalence is 0.1%, but we are seeing more and more patients because the population is getting higher and older. And this is why, because mainly the incidence is in the 70 or 80 years old. It's 2 to 3 times more frequent in men than women. We don't know why, mainly for the type of tissue that is there in different genders. So the pathophysiology is not completely understood. Most of the author thinks that in the upper esophageal sphincter, there's a motility disorder that can facilitate this herniation throughout this weakness area that is the Killian triangle. When is indicated the treatment? Let me say always when the patient has symptoms. And historically and basically, we can define 3 types of treatments. We have the surgery, that is a cervicotomy, open surgery, or a transolar surgery with rigid endoscope, and we are talking about this, something done with flexible endoscopy. That it is basically called the transoral flexible endoscopic septum division, because what we are doing is not a diverticulectomy. We are not removing the diverticulum, but the main goal and the rationale is that we are opening the diverticulum in the esophagus. So we are dividing the septum. And this is why we call it FESD, that is a flexible endoscopic septum division. I have some video also just to all the audience understand what can be done for different treatment for Zenker. This is the classical surgical procedure when they are dividing and dissecting the structure nearby the diverticulum, isolating the diverticulum itself, that then later on will be cutted and separated into the septum, and then they will add a small myotomy, try to prevent the recurrence and also the stricture done by the stapler. But this is surgical, it's not our aim. Then we can also do it, usually is by the otorhinol surgery via a rigid endoscope. And this is exactly what we are doing endoscopically, because we are phasing the diverticulum and the septum. And in this way, via a rigid stapler, they are dividing and cutting and suturing together the two sides of the opening of the septum. But endoscopically, with a flexible endoscopy, this is what usually we see. We see a tissue that is in between two different pouches. One pouch is the diverticulum and the other one is the esophageal lumen. So the first aim is to always remember which one of the two is the luminal side and which one is the pouch. Otherwise, we can make a very big and huge complication. The approach endoscopically has been described in 1995, and the rationale, as I was saying, is exactly this one. So trying to cut the septum that is in between the two lumens to let the pouch opening in the esophagus. But so it means that we are not removing the diverticulum. It's not a diverticulectomy. So to create a single pouch between the diverticulum and the esophageal lumen. As I was saying, it was first described in 1995 by Professor Ishoka from Brazil, and this was the very first paper published with 42 patients. And for the first time, I said that you saw total session per patient, it was 9.8. It means that this type of treatment is repeatable in case of recurrence. All of the series, they are describing recurrence. So sometimes just one session is not enough to relieve the patient from the symptom that is or she's having from the Zenker. They reported in the first paper 2 complications. There was a cervical emphysema, but they've done only conservative treatment, so no need for surgery, and 1 bleeding, but also this one was managed endoscopically, so none of the patient needed surgery for complication after the treatment. Nowadays, we know that fortunately, we have some devices to help us in having a safe and fast treatment for the Zenker. The most known is the Diverticuloscope. That is this overtube with 2 different arms. One, the small one will go in the pouch, the other one, the longer one, in the esophagus. And this will help us in stretching the tissue and to really expose in a best way the septum that later on we're going to cut. In my personal experience and in my unit, we don't use the diverticuloscope, but let's say that we use a free hands cutting, just adding an endoscopic cap at the tip of our scope to have a better stability and to see what we are doing. And then regarding the knife, you can use a lot of different instruments. So as been described, the forceps, the ESB knife by Sumitomo, or the classical hook knife or similar knife, or the historical needle knife that they use for the pre-cut in the RCP. Personally, from our group, we published in 2010 the first historical quote using with the hook knife. We call it the pull the fibers technique. It means that with the hook knife, we can really hook the fibers, and then by pulling, we can safely cutting. And this is what we do. So once we enter with a cap, we saw these 2 pouch. We used to add an orogastric tube in the esophageal side, always to remember which one of the 2 pouches is the esophageal side, but also to have the space while you are cutting to let the esophagus opening by your cutting. And step by step with the hook knife, you can arrive to the end of the pouch, the very end, where usually your myotomy should end and should finish, and then apply endoscopic clips to prevent delayed bleeding and perforation. So one of the main questions, and meanwhile I speak, I will show you a standard flexible endoscopic treatment. One of the tricks is to cut exactly in the middle of the septum, because while cutting, it can happen that because of the high pressure, it can turn a little bit, and then it's difficult to cut and to understand exactly where the fibers are running. But one of the main point and question that everything is approaching to endoscopic treatment of Zenker is saying is, when should I end my myotomy? Because if you cut too much, you can have perforation. That means a very big complication in the posterior mediastinum. But if you don't cut enough, you will have a recurrence because the muscle will stay here. But with a good myotomy, this is what you will achieve. This is an X-ray before the endoscopic treatment and after. So you see that the pouch is not there, but you can see also some clips still there. That means that the pouch is completely open in the esophageal side without any remnants. But the diverticulum is there, but it's not a real diverticulum anymore. This is the point. But from a pioneer that is present here today and is the president of this session and this event, we are going even further. So from standard flexible endoscopic septotomy, we are going to the third space. You know that, as I said, FES was introduced 20 years ago with comparable results with surgery. We have a lot of meta-analysis say that the recurrence is not so high, the complication is not so high, but because we are going in the third space, we need to change something. And starting from that point, it was 2010 when the first paper by Professor Inoue was published about POEM for achalasia. Now we are going in a new revolution. I used to call the third space revolution, because it's the first space is our luminal side, and the second space is something that means for us still complication, because we are going outside from the lumen, that could be in the thorax or in the peritoneum. We are just working in a new space that is a virtual space we are creating, that is the submucosa and the third space. And in the third space esophagus, they already in this revolution, they already try to do a lot of different techniques depending on the type of diseases they were to treat. So for standard achalasia, we have the POEM or esophageal POEM, but then you can use this approach also for subepithelial tumor or for refractory gastroparesis with the GPOEM. And today, the focus of this lecture is the third space endoscopy for Zenker diverticulum. So try to resuming the three now treatments, all of them with flexible endoscopy we can make for Zenker. We saw right now the flexible standard endoscopic septotomy, the one that I showed you till now, but then using the third space approach has been described the so-called Z-POEM or the new one that is the POES, and we'll see the latest two of them. So why to go to the third space if the FES is working better? Because we have some theoretical advantages, that is reducing the risk of perforation and mediastinitis, and by phasing exactly the muscle that we are cutting, we can theoretically also reduce the recurrence rate. The fact is that maybe the third space is not really feasible for very large septum diverticula, because we are not cutting the mucosa, but just the muscle by entering the third space. So we are creating this redundant mucosal flap. And then it's a little bit tricky, and because you are working nearby the upper esophageal sphincter, so your working space is not so big. So somehow they are saying that maybe it's not so easy, and the first is so easy and working. So why we are going through that? And we'll try to answer to this question. So this is the typical image and picture you will face when using the third space approach for Zenker. You will see that you have the diverticulum submucosa, the muscle that has been transected right now, but then you have also the esophageal submucosa. So you have two different submucosa because you have the pouch side and the esophageal side. And potentially we said that this procedure will reduce perforation, mediastinitis, and mainly recurrence. So the concept of the Z-POEM is to create a proximal incision, injection, and then incision, and then to enter in this new tunnel and to face directly the fibers of the septum to later on cut all of them till the esophageal muscle and close your initial mucosal incision by clip. And we are starting finally having some good results. So this is a retrospective comparison between Z-POEM and FAST with more than 200 patients. Most of them have done Z-POEM. There was 119 cases, and they achieved a clinical success in almost 93% of patients with Z-POEM, with a recurrence that it was up to 15%, so not so low. And the reported adverse events, that was only mild, moderate, so none of them needed surgical revision or very aggressive treatment. It was up to 17%. So it's a little bit complicated procedure, so it must be done in really expert hands, in person that know what they are doing. And finally, this is the largest Z-POEM series available, but the efficacy is similar depending on the endoscopic technique we are using. But still, the recurrence is there, even if they are a good safety profile. So what we thought is, just for short septum diverticulum, is to apply a modified Z-POEM that we call POES treatment, and POES is peroral endoscopic septotomy, because the main goal is exactly the same, to cut the septum in between the pouch and the esophageal side. But because we are working in a very narrow space and you have the upper esophageal sphincter, so it's difficult to work there and to create a mucosal incision proximally to the septum, we thought that maybe it would be easier to inject and to cut directly on the top of the septum, to make the mucosotomy exactly there. And then by entering the third space, we were already there, ready to cut the muscle. And sometimes, you know, we don't go exactly for all the tunnel in the two sides, but we go directly together, tunneling and cutting the septum. Because once you arrive till the bottom of the pouch, your job is done. You have to stop. You can cut a little bit more the esophageal muscle, but as far as you cut all the septum, you are really getting lower all the recurrence, because the problem is the septum, it's not the esophageal muscle. And this is this variation between the POES and the Z-POEM. And we published very recently the first initial pilot study and then some other results. Now we have we have some data about midterm success and results to 2 years, no more than this, because it's something very recent. And so far we had just one recurrence of POES, where really there the problem was an incomplete myotomy from our side, because even if you are able to see exactly where to cut, it doesn't mean that you are cut all of the muscle. And in that case, for that single recurrence after POES, I did a Z-POEM, because was the only thing that I can do, because I have all the fibrosis in the mucosal side just above the diverticulum and the septum. But let's see the POES, how it's working. So the difference is that we are injecting just on the septum. The orogastric tube is already there, always to remember where is the esophagus. And then using a hook knife, we are still injecting to create the submucosal cushion and prevent recurrence. Diverticulum on the right, septum just in front of us, and on the left side, the esophageal. And this will be our mucosal incision. So we usually use the hook knife, and step by step, we can create this mucosal incision large enough to let our cup and our scope entering in the third space. But because we are just above the muscle, as soon as you cut, you will start cutting a little bit the cricopharyngeal muscle fibers. And step by step, we will be able to enter with our cup, because we are creating a new space. The third space is a virtual space. And by injecting and entering with the cup, we are creating it. So we can or push and cut the fibers, or with the hook, pull, grasp them, and then cut all of them. Step by step, we'll be able to enter, and we'll see the muscle in the middle and two different submucosal sides. On the right one will be the diverticulum, on the left side will be the esophageal submucosa. In this way, you will be able to cut all the septum. During the procedure, if you need, you can inject again and make your tunnel both sides a little bit bigger. But as soon as you see now the esophagus is open, then the esophagus is open, and it means that also the bolus and the food will be able to go directly in the esophagus. You have to clip it to close your entering and to prevent complication. It's a 10 to 15 minutes procedure. We are doing this procedure without any orotracheal intubation. So the patient is just sleeping with propofol. Just in few cases, we got the patient intubated. If we see that the position is really unstable or the patient is unstable, so in that case, we discuss with our anesthesiologist and we intubate the patient. But it's less than 5% of all the patient. Talking about results, this was the first pilot study published in Endoscopy in 2021. So far at that time, we've done 20 patients and under propofol deep sedation in less than 15 minutes in average time with no intra or post procedural. We were able to make a successful complete myotomy in all cases but one. So that case was not possible for a lot of fibrosis there. And so we had a success rate of 95% with no recurrence. I told you that now we have in more than 70 cases, one recurrence that I treat successfully with a Z-POEM done after a POES. So the efficacy and recurrence rates has been comparable to Z-POEM and standard septotomy with a favorable safety profile and probably lower adverse event than Z-POEM because it's faster and you don't need to create a long tunnel to face the septum because you're already there. You're just injecting and entering the third space just above the septum. And a short procedural time also compared to Z-POEM. Most of the others worldwide, they are doing the Z-POEM also with patient intubated, that it's been a very longer procedure time. We know that at that time was just a pilot study, but we are doing every day. So I can tell you much more results, not yet published, maybe in the near future. So to conclude, I can say that till now, the flexible endoscopic treatment is the best treatment, is the gold standard for Zenker diverticulum, much more than the surgical approach. And still, maybe the standard septotomy can be considered the gold standard compared to the third space. But the third space gives us a really nice approach, easy approach, and also a lesser recurrence because facing the muscle, we are able to cut all of them and to prevent early and late recurrence. The Z-POEM and POES show comparable efficacy compared to the flexible endoscopic septotomy, but maybe the third space is associated with lower risk of recurrence compared to the flexible endoscopic septotomy, but we still need further data. And with this one, I thank you.
Thank you. Thank you. That was a very interesting discussion, Roberta, as always. No? Thank you very much. There are just a few questions that come to mind, and I think Dr. Shimamura has some comments and maybe questions. So please, Dr. Shimamura, go ahead.
Okay, thank you. Thank you, Dr. Masali, for the wonderful lecture. Learned a lot from your great talk. I have several questions. First, do you prefer to perform POES for all cases from now, or do you still perform Z-POEM?
So in our unit, we do perform a standard septotomy, so the FESD or the POES. We do not perform Z-POEM because of all the limitation that I told you. It's not just because of the orotracheal intubation, but just because really it's difficult in my mind and in my side to create a submucosal tunnel proximally to something that is nearby the upper esophageal sphincter. So you have really no space. So only if the patient is really intubated and deeply sleeping, you will have maybe a chance to make it. Otherwise, you are complicating your life instead of make it easier. This is our great point. The other fact is that it is still in our mind, in our rationale, you are doing third space endoscopy, regardless if it's Z-POEM or POES, just for very short septum diverticulum. Otherwise, you will leave the mucosal flap over there, that even if it's not muscle, it can create symptoms because the food can be strictly there on the pouch instead of going smoothly smoothly in the esophagus. So you are still creating a sort of a step there if you don't cut also the mucosa. So our clinical and practical approach is, in case of large diverticulum, to go for standard septotomy endoscopically. If it's a short one, then we'll move by injecting, entering the third space, and make a POES.
Okay, thank you very much. The last question I have is, if you have this redundant mucosal flap after POES or Z-POEM, what do you do with this redundant mucosal flap?
So theoretically, you should not have it if you're done only for short septum. But in case you've done this for large septum, you still can cut it. The fact is that why not to go directly for a standard septotomy if you have to cut mucosa, submucosa, and muscle? So why you are complicating your life is injecting the submucosa, cutting the submucosa, cutting the muscle, then come back and cut also the mucosa. I don't know. I try to always do something in the best way, but also in the faster way possible.
Thank you very much.
Thank you. Thank you, Roberta. I just have maybe a couple of questions for you. So recurrence is a real issue, whether it is Z-POEM or POES. Although in your series of POES, you've shown that the recurrence rate is quite small, smaller than that of other techniques. And theoretically, patients with larger diverticulum are more prone to have these recurrence of symptoms. Now, does the length of myotomy during POES have an effect on this?
It is a very good point and very good question. And this is exactly the reason why we thought to enter in the third space also for Zenker, not only for achalasia, as Professor Inoue has done 10 years ago. Because the main question, every time we have some fellows or somebody coming to us to learn the treatment of Zenker, they always ask us, when do you know when you have to stop? And this is a great question and nobody knows, definitely. Because if you don't cut enough, you will have a recurrence. If you cut too much, you're opening the posterior mediastinum and you are making complications. So it's always different to understand when to stop. And with the third space endoscopy, because you're having the mucosal flap that is saving you from complication, you are able theoretically to go through all the esophagus if you wanted to make a POEM, if you want really to be sure that you have cut all the muscle possible. And this is why also answering back to that question, maybe then cut the mucosal flap that is your saving flap is not really the best, but in case you need, you can do whatever you need. So that's not a clear answer. The answer is as needed. So if you know that you have a 2 centimeter septum, your myotomy should be at least 2 centimeters. So you have to cut all the septum. Once you opening the septum, you will see that the esophageal side will open. And that one is a great landmark that you've done your work. So at that time, you should stop.
Thank you. And the next question is, may I know what clips you use? What is your experience?
I use all the type of clips I have in my unit. So there's really everything you have, you can use it. The fact is that, and this is the other reason why we went for POES instead of Z-POEM, that the patient will have a discomfort while swallowing, even the saliva, because of the clips. So putting the clips proximally to the septum, that there's the upper sphincter, it will be very difficult to place it, and then the patient will have a lot of symptoms. Placing that on the septum, the patient is just experience a small discomfort just in the first very day. Just the second day, it will be fine. So every type of clips you have, unless you are placing in the proper way and they are really closing and having the force, it's okay.
Thank you very much, Roberta. It's a very, very, very excellent lecture, and you have the huge experience of POES. So I have a very simple technical question. So do you place the mucosa incision? So when you perform the POES, so do you follow the top of the septum, or you place the mucosa incision? So not parallel to the septum top. So you place the crossed tangentially, so that's a question.
No, I follow the shape of the diverticulum, so is exactly parallel to the septum.
Okay.
You know that when we have very, very short diverticulum, because sometimes you have symptoms with the small diverticulum and small pouch and small septum, in that specific case, I put some mark on the septum, because while you're injecting, you lose the septum. You don't know where the septum is anymore. So I put some marks, inject, and then I follow it. I'm connecting the dots to follow the marks parallel to the septum, to face the septum just while entering in the third space.
Yeah, that is a very important tips. Thank you so much.
Thank you. Thank you.
So I guess this is it for this session on Z-Poem and POES. Thank you again to Roberta for your generous time, for sharing your time with us and informative talk. Please stay tuned for the next session in the Tokyolive endoscopy.